between 1:30.
1:30. So let me see how many slides.
Yeah, how many slides you have? Okay, so we can just. Yeah, I think. Yeah, because usually the plenary they don't have the discussion, but I don't know if this one is for us. I think so, but anyhow. All right, I think. Yes. Good afternoon. Welcome, ladies and gentlemen, to this plenary session on antithrombotic therapy. I'm Flora Peivandi from University of Milan, and it's my pleasure to welcome and to introduce Professor Harry Büller. He is a professor of internal medicine and from Department of Vascular Medicine, Amsterdam. I don't think Harry needs any introduction. I think he's the most famous trialist and is a person who brought, actually, I would say, the evidence-based medicine in this field, and we are very happy, Harry, to have you here. So I think if you can stay with 45 minutes, we will have a chance to see some of the discussion and questions.
Thanks very much, Flora, for that introduction. Everybody starts like that, but I feel it really a privilege to be invited by the organizing committee to talk about my favorite topic, which is antithrombotic therapy. I apologize for some of you, some of the information may be a repeat, but I have learned that if you repeat things from time to time, it actually is easier to memorize. So what I would like to do after I showed you, I've seen so many people that have no conflicts of interest. Now, I am full of them. I actually conflicted all over because I've been, had the privilege actually to work with all the companies that have developed these new agents, which I think is the best way to prevent any conflict of interest. If you disclose one, I always get nervous. If you disclose 8 or 10, I feel fine. Let's get to business. So what I thought I would do very briefly is the history, where we actually accepted the use of anticoagulants in the treatment of venous thromboembolism is actually pretty young, as I will show you in a second. Clearly, the main part of my topic is about direct oral anticoagulants. I've done that so often that I thought it might be useful to do it slightly different. Because when you give a talk on DOACs, then you get these questions later about being critical about this and that. So I thought, why don't I play both? I do play the good guy and the bad guy in one presentation, so that after this presentation, you can ask the questions you want, which I forgot about. And then finally, and you've already seen some of that in the presentation this morning by Thomas René and others, is what are we going to see in the next 5 to 10 years in terms of the anticoagulants. And I can already assure you that while in the DOAC area, we had this battle of are you in favor of a thrombin inhibitor or are you in favor of a 10A inhibitor, now has been settled by the clinical data, but you will witness, probably when I'm retired, is the factor 11 or the factor 12 battle. And we're going to see, hopefully, lots of evidence there to actually answer the question, is factor 11 a better target or is factor 12 a better target? And at the end of my talk, I just give you some overview of where we are. So we started anticoagulant therapy in 1938 with the purification of heparin. And heparin, probably as most of you know, is these beautiful sugar chains that are derived from the mucosa, the gut mucosa of cows and pigs. You can imagine that in the beginning, when these drugs started, they were purified to some extent, and at the time when they were given, there were quite some feverish side effects of using heparin. The other one is also very familiar to you, which is warfarin, which actually stands for the Wisconsin Alumni Research Foundation. So it was invented in Wisconsin, and the patent was to the university. You don't see that very often these days, that good researchers are so happy with the university where they work that they give the patent of these new agents to the university. Most of the time, they start an own business and forget about the university. Now, of course, it's much better known as a poison for rats and rodents in general. So this is the part that I showed you in the history. And it's quite interesting if you go back to that old literature, and some time ago I actually did that. It's at that time, there was the most simple outcome measurement, is count the bodies. How many are still alive at the end of the experiment? And it's interesting to see that in 1938, this is the really first study, that heparin was given as a sole drug for a couple of days. And in this publication that is followed by this one in 1946, you see the speed of these developments take really many, many years. And this is a beautiful publication. They said we treated 209 patients and only 3 died. That was really the simple period of research. Now, as you can see, there are a couple of other ones, but this, dear colleagues, was the study that really changed the field. Barrett and Jordan, one was a surgeon, and the other one is what we call today a vascular medicine specialist, and they were fighting all the time. The surgeon said, if you give anticoagulants, you ruin my surgery, and the internist said, if you don't give anticoagulants to these patients with VTE, they're going to die. And so they did appropriately what they needed to do. They did a randomized trial. And what kind of randomized trial? They compared heparin, and here you see the introduction, actually here's already that introduction, is heparin and some kind of a vitamin K antagonist. And the beautiful sentence in this Lancet publication is, much to our surprise, we had to terminate the trial prematurely. Now, they had to terminate the study prematurely after only 35 patients were included in the 2 arms. And so this was because the fatal recurrences and the non-fatal recurrences were extremely high. And it is really, that is the starting point that people started to accept anticoagulant therapy for the treatment of venous thromboembolism. We took another, as you can see here, from 1972 to all the way up to 2005, arbitrary, is actually to establish, to use the APTT for heparin, the INR, some initial studies on the duration, but it really was a very slow development. And then, really, thanks to the investments in basic science, we start to understand how the coagulation system worked, because I forgot to tell you that heparin and, of course, vitamin K were found not by specifically looking, but actually by good luck and good observations. However, in the 80s, 90s of the previous century, a lot of our understanding increased in terms of the coagulation cascade. And together with that better understanding, we have now, as you can see, a simple coagulation scheme. But also what you can now appreciate here is we have at least 6 different possible classes of anticoagulants. The first one is, this one is the interference with the tissue factor 7A complex. And interestingly, although the drugs have been tested initially and where some were successful, they have died. At least I have never seen publications in the last 5 years. A lot of the attention, as you can see, is here interfering with the activity of factor 10A, or the 10A inhibitors. And here are the usual suspects, rivaroxaban, apixaban, edoxaban, and let's forget about these ones for a minute. And then the dominant position of here thrombin in the coagulation system. Some people in some parts of the world actually believe that's all about thrombin. And 10A inhibitors were delayed in their development because they did not affect thrombin. Now, as I will show you in a second, the 10A inhibitors work very, very nicely. But here we have dabigatran as the one that really is the class, so to say, oral drug in inhibition of thrombin. I have no time to discuss these ones. I will touch on the early developments in factor 11 and 12. And I already promised you that is going to be absolutely fascinating. If you are young and eager and want to become very, very famous, you better start coming into this field, because 11 and 12A are going to be the drugs of the future. Let me now switch to my second part. This slide, as you can see here, is not to discuss in great detail, but just to introduce to you the different studies, the Hoxai with edoxaban, the Einstein studies with rivaroxaban, the apixaban amplify, and recover. Now, what I will do in the next 5 or 10 minutes, I do see these four to have more in common than they actually are different. To me, they are four beautiful children, my own children, to some extent, and I am not able to choose or have a favorite child, and I will not have a favorite drug. What I would do, though, is look from a bird's eye view point of view to what have these drugs given us and what are the potential advantages and probably also disadvantages. What I'd just like you to remember is, and this is pretty unusual if you look at these numbers, there are more than 28,000 patients studied with DOACs in the field of venous thromboembolism. As you can see here, studies of 8,000, and this also 8,000, 5,000. As you can see, we have come quite a long way if we compare that to our cardiology colleagues. They are used to large numbers. But in the VTE field, we did, in the treatment at least area, we did studies with 2 times 50 or 2 times 80, and now we have a database of almost 28,000 patients. Now, why am I so confident to take this bird's eye view? And that's because of this following element. And that is the last two. In all these trials in the DOAC, whether it be 10A inhibitors or thrombin inhibitors, they used an identical definition of efficacy and safety. Now, this is important because if you say in this study it's a recurrence, it's the same recurrence in the other studies. And so you can take this look and look at the meta-analytic view because you are confident that the recurrences or the bleeding are defined in exactly the same way. More importantly, it was by the same adjudication committee for all these 4 studies. So not only the criteria were identical, but it was the same group led by Martin Prince in Maastricht, who actually adjudicated these outcomes in all those studies. And that gives us the possibility to actually combine these studies because we are comparing apples with apples. And I can give you a number of examples in other areas, in myocardial infarction or in stroke, where the definitions of the outcomes are slightly different or sometimes importantly different. That's not the case in this particular setting. So here I start, and I tried to have 2 voices, but that sounds so silly that I will play both the good guy and the bad guy with the same voice, and you can just imagine whether you feel more identified with the good guy or with the bad guy. Here we go. I just introduced them to you. This is, of course, the good guy, and that's the bad guy. In the field of DOAC trials, I would say you can also characterize these folks by the following, and that is This good guy believes in trial data, is a pathologically optimistic person, and really loves progress. The more, let's say, critical guy, the bad guy here, is critical about industry-sponsored studies. There are even colleagues who don't even read the ones that were sponsored by the pharmaceutical industry. They disapprove change, or they only change very slowly. And then, of course, you have what I now call the tricky triangle, and they do exist in many parts of the world. And that's the combination of Calvinistic doctors that want to stop and let me see another piece of information. One trial is no trial, that type of carefulness. And interestingly, it's very often the same people, and it's independent of the type of drugs. I'm young enough that we have seen the switch from unfractionated heparin to low molecular weight heparin, and unfractionated heparin was hated because you had to give an infusion and you had to take the APT, rush to the lab, get back, adjust it, and then low molecular weight heparin came. And then these Calvinistic colleagues became absolutely upset. Oh gee, a fixed dose, I cannot measure anymore. I'd rather use IV unfractionated heparin. Now, these guys and girls take some time to adapt. Now, of course, the anticoagulant clinics is a part of these tricky triangle for reasons that I don't have to explain to you. And of course, as soon as money is involved, government and insurance companies become a part of this tricky triangle. So here is the first concern of our good friend, the bad guy. He said the trials included insufficient numbers of older people and renally impaired. I only care for those elderly people above 70 or above 75, and they, of course, were excluded from these trials. Or I have older patients that are really renally impaired. And his other one is, and this is the most beautiful one, the results, can they be reproduced in the real world setting? Now, nobody knows what the real world setting is, but that's a bad guy argument, that is it also true in the setting of the real world? Because those ones outside of these trials are, that are not entered in these trials, that are the ones that I'm caring for. So let's then look what happens. Now the first one, and this probably is one of my most important slides in terms of content, because I got a grant to review, and they said, these trials did not study patients that are older, and we want to do 2 times 150 patients above the age of 75. Now, I wrote back in my review that you don't actually have to study that, because if we look in all the DOAC trials together, and I'd like to draw your attention, 1,800 patients in each group actually were above the age of 75. So they were not excluded from these trials, they were actually inside in the trials. But why this is the most important slide is if you look at these ones, this is the frequency of recurrence in the elderly. And I know elderly varies when you get above 70 or above 75 or 80, that suddenly changes, I learned. But look at this, the recurrence rate is 3.8% in people simply characterized by age above 75 and a VT. And what you will appreciate, this is the rate of recurrence on the pooled DOAC, and here is the way I will present it in a number of slides, but you will appreciate this is the point estimate, and the confidence interval actually lies to the left of the line of identity. These are subgroup analysis, sometimes subgroup for subgroup analysis, but I think it's fair to say that at least, and if you want to judge this based on the relative risk, it's the elderly that really benefit in terms of efficacy. Now there is something else, and that's if you look at the major bleeding. Here, look, my dear friends, on warfarin, this fantastic drug, warfarin, that we can monitor. But it's 4.1% of carefully monitored patients that develop a major bleed. Look at the difference here below. This really is, as you can see here. So it's the elderly where most recurrences occur and where most bleeds occur. And as you can appreciate from this comparison here, is the rate of bleeding is 1.8, 4.1. So clearly in the elderly, it's the one that benefits particularly. So if there's one group to consider giving DOACs, actually it should be the older. Let's turn, and now you are used to the way to interpret these data, to the renally impaired. It was a big concern and say, oh, gee, you know, I have patients with a renal clearance, estimated clearance, between 30 and 50. Below 30, we have no data. The FDA is so wise that in the absence of data, they are able to recommend doses for renal patients. If you do that, if you make up guidelines and extrapolate data and without studying it actually, you are criminal, but if you work with the FDA, that's no problem. But what is the message here? The message here is the same as in the elderly. 4.4% recurrence, as you can see, and that's 2.9. So it works very nicely also in the renally impaired patients. What about bleeding? The same picture. Now, it's true, of course, that age and renal insufficiency, and if you want body weight, overlap. But if you really take them apart, then the same picture emerges. So therefore, the evidence that we have both for the renally impaired, and again, this is 890 patients in each group. This is quite a significant proportion of these patients actually had a renal clearance between 30 and 50. Let's then go to that second concern, the real world. Now here, I have to borrow some information from the atrial fibrillation, simply because the data for venous thromboembolism is coming. The first one is the Xalia data from Walter Ageno, and in that one they actually compared rivaroxaban and VKA, and in the Dresden registry there's a similar picture. But what is the interesting observation here is this one. The relative benefits on bleeding appear to be confirmed. So although maybe in the real world the rates may be slightly higher, the relative effects of the DOACs seem to be persisting in the so-called real world. Here, I do borrow some evidence from, as I mentioned, from the atrial fibrillation. Now, some of you who are working in the area of atrial fibrillation, the first large study was the RELY study with dabigatran. And the FDA, I talked about the FDA earlier, was very concerned that the trial data were going to be very different from what they call the real-world data. So the FDA sponsored an analysis where they looked at more than 136,000 individuals that either used vitamin K or dabigatran in the real world. And this is the picture that emerges. And the only way to look at this is like this. So this is ischemic stroke. You see here the relative difference. This is the Medicare. This is the 134,000 patients that were studied by the FDA. And I can tell you why they started this analysis. Because, as I mentioned, they're concerned. They were actually very concerned to find big differences. But look at here. This is ischemic stroke. This is intracranial hemorrhage. This is major bleeding. This is GI bleed. That's MI, and it's the total mortality. What was seen in the trials was perfectly mirrored in this so-called real-world setting. And there's many more data, and I have no time to discuss all of them, but hopefully, for venous thrombosis, we'll have some evidence. So let's go back to our two friends. Are you happy with these data? Now, you know the answer, because if it would be yes, my talk would be ended. But let's see what happened here. Maybe less bleeding, does the bad guy tell us, but I hear these stories, more gastrointestinal bleeding. And bleeding at presentation might actually be no more severe, and there's no antidote. All right, So the good guy has to go back and work and provide the data. And here you see the data. This is, again, from all studies together. I don't pay attention to actually some differences, because they actually are not different. But one thing is for sure, if we take the DOACs together, as you can appreciate here, there is a 39% reduction in major bleed over a period of about 8 months. Some of the studies were 6 months, others 12. But if you take the average time of follow-up over a period of 8 months, what you do see is, if you want, 1.8, 1.1 are the absolute terms. All right. What now about these GI bleeds? Here are the different components, and I have to warn you, there is some overlap, of course. But if you look at intracranial bleeds, which is a part of major bleeds, of course, what you can really see, low numbers, but very feared. People that start warfarin, physicians, but probably also patients if they go to the internet, is the concern that there actually is a risk of intracranial hemorrhage. Now, it's not high, but there is no doubt that the risk of intracranial hemorrhage is clearly reduced, as you can see here, if you like this, by about 60%. What about gastrointestinal bleeding? This is major gastrointestinal bleeding. Now, dear colleagues, in the setting of VTE, there is no evidence that there are more major GI bleeds. Are there more smaller GI bleeds? Yes. Are there more hemorrhage or more menses-related bleeding? Yes. But in terms of the major bleeds for gastrointestinal, they're really 0.6, 0.5. Fatal bleeding is there. And here you see clinically relevant, non-major. Now, keep in mind that the frequency of clinically relevant is about 8 to 10%. And that's a very frequent reason for physicians, but also for patients, to stop treatment. The major bleeding rate is about 1%. So it really is the clinically relevant non-major. Somebody who has a nosebleed for half an hour needs to go to the emergency room, or somebody that has microscopic hematuria or a large skin bleed. That will never become a major bleed. Somebody who coughs up a cup of blood will not become a major bleed if not transfused, if the hemoglobin doesn't drop. But those bleeds are important, and as you can appreciate here, reduced by about 25%. And then some unpublished data, so if you really like to look at this, you're happy. If you put it on the internet, I will find you, because this is unpublished data. What we have done, with the help of some of the folks in this audience, is we have looked at all major bleeding episodes in the venous thrombosis trials with the 10A inhibitors. And what we have blindly done, together with Ander Cohen and Saskia Middeldorp, is actually reclassified these ones into this category now. And I'd like you to have your attention for this one, number 3, bleeding events that present with great medical emergency. You are in charge in the emergency room, and this patient comes in, and that patient really scares you. You have to do everything to really help that patient, or this category number 4. And because of time, I cannot go into much detail, but the bottom line is, if you now take all the bleeds that were seen in the trials of venous thromboembolism, this is the picture. And what you will see is in category 3 and 4, which we a priori defined as the group of interest, as you can see, this is 35%. So about 1/3 of the bleeds on a 10A inhibitor fall in category 3 or 4. This is actually 48% in the bleeds that present on warfarin. And if you like statistics, this actually suggests, or is statistically significant, decrease in the severity of the clinical presentation. We also looked at clinical course, and that actually was not very different. Now, our bad guy was concerned about that these bleeds were worse, and his last argument was antidotes. And here you have the data for the antidotes. We now have idarucizumab for dabigatran. This now has been studied, and the report about the total number of 500 patients will come very soon. There is an immediate reversal, and it is actually approved. And yes, there are bleeds in which you are happy you have this reversal agent. The great majority of bleeds you can do by whatever you already did. But there are indeed some bleeds that we are very happy to have that reversal agent. Now be careful, this only works for dabigatran, so don't give it on a patient that uses apixaban or one of the others. And that's the andexanet. Now there is immediate reversal, that's what was presented at the European Society of Cardiology in August in Rome. There is immediate reversal, so it takes the drug away, but we really have to see its long-term efficacy and safety. So let's go back to our two friends. Are you hesitating, my good friend? This is the optimist, of course. No, of course not. He is not yet hesitating because he has another argument. Versus well-controlled vitamin K therapy, DOACs lose their advantage. So if your INR is in the upper range of the therapeutic range, let's say in the 60s and the 70s, you lose the advantage of the DOAC. And of course, this comes from patients on VKA. They are so happy. They go to the anticoagulant clinic. They bring their lunch and their pictures of their grandchildren and can share that with the other ones. And it's a very cozy, very friendly setting. And so he argues that patients on VKA are happy and do not want to switch. All right, let's then look at the evidence. So our good guy goes into the literature, and here I borrow data again from AF, but I can tell you for the VT, we now at least for two studies, for the Amplify study and for the edoxaban study, we have exactly the same picture. And what is that picture? And that's this. So if I start here, this is apixaban. These are quartiles of the center TTR. So this is the best. The fourth is the best quartile, so that's up in the 70s. And as you can see, whether you are in the fourth, third, or what, there really is no loss of efficacy. There was this observation with the 150 milligram dabigatran. In the 110, you don't see it, but in the 150, and it got a lot of attention, because this was taken as evidence that actually, if you go to the third, fourth, you go more to the line of identity. Now, that happened to be an outlier, because now if I add the evidence from the venous thrombosis, it really looks like what you see here or there or there. So a good quality warfarin therapy really does not negate the effects. This is on, as you can see, on efficacy, and the same is true for safety. Now, the other argument that the bad guy used is these patients are happy on their warfarin therapy. Now again, this is unpublished data, and maybe some people in the audience have actually reviewed that, and my favorite journal returned this with this is a fatally flawed study, and I'll tell you in a minute why that probably may not be true. But what we did here, again, this is unpublished, so don't put it on the internet. We took 200 patients from the thrombosis clinic in Amsterdam that were treated for venous thrombosis for a prolonged period of time. Actually, we wanted them to be treated for at least 6 months, so they had experience. It turns out that the mean duration is a couple of years, actually. And what we got is 135, that's a 68% response rate on a questionnaire. Now, what we did with these ones, and again, I don't have time to go in great detail, but what we did here is actually used a method, trade-off technique, which is that fatally flawed technique. However, it's extensively used. I only put this reference here, but I can give you 6 or 7 references. It asks the patient with a scenario whether, because of that scenario, he or she wants to switch from warfarin that they have right now to possibly a DOAC. And then the first scenario is the simple message. They are equally effective, they're equally safe. The only difference is you don't need to come to the anticoagulant clinic to have your blood drawn. That's scenario one. Scenario, which is true, of course, because the DOACs, you don't have to come to an anticoagulant clinic. The second is also true. I showed you that, there's less bleeding. So the second scenario is that, in addition to not coming for your anticoagulant, to the anticoagulant clinic, there is a small advantage in terms of bleeding. And of course, this is no interaction food, and we put in this purposely as the last one, because that one is, of course, not true. We have no evidence that the efficacy is better. These were, as I showed you, 136 patients that were on warfarin on average more than 2 years. In scenario one, which only offered the opportunity not to come for an anticoagulant clinic visit, about 36 of these patients said, then I do prefer a DOAC. If you added the information about the less risk of bleeding, this goes up to 57. This is less interaction with food and other drugs. And really, as you can see, there is no difference. Efficacy. Patients do not pay attention to efficacy. Patients do pay attention to the need for blood, coming for blood testing and some safety aspects. So, still not convinced, my dear friend? Of course not. Because what he says, if there are benefits, they are small in absolute terms. And together with the cost, these DOACs are not cost effective. You see this, the different lines of defense. Now let's look at what it is here. Here is the number needed to treat for approximately 6 months a patient to prevent one event. Now, in the overall population, you need to treat 143 patients to prevent one major bleeding episode. In terms of intracranial, it's about 1 in 500. And you can take it your own way, but if we go to the elderly, it is actually 1 in 43 patients. So you need to treat 43 patients for 6 months with a DOAC, rather than with a vitamin K, to prevent one major bleed. Unfortunately, I could not calculate the intracranial because the data cannot be split, unfortunately. So therefore, the big question is this cost effective? Now, we actually have a wealth of data. Now, the best one are these from NICE, that's the institution in the United Kingdom, the National Institute for Cost Effective Analysis. And they have first analyzed rivaroxaban. And the terminology that is used in cost-effective analysis, if you take a society perspective, so you not only take the drug cost, you don't not only take the laboratory cost, but you also take the cost of an intracranial bleed or somebody that has to be in hospital or in a people's home for a long period of time because of the complications. So it takes the total perspective. And what you can see, rivaroxaban dominated the therapy with low molecular up to 12 months, and even longer. So it is simply cost effective. Now, those of you who are familiar with the NICE technology that they use, is pretty strict. For the other drugs, the bigatron and edoxaban, and you can see for those who are interested, is we also have that evidence. This is in the setting of venous thromboembolism. I see that you are in doubt. Hopes to see that with the guy, the bad guy, the good guy sees that. Not yet. Phase 3 trials have design flaws. Some of them are non-inferiority, and some are even open-label designs. Cannot be good. And finally, cannot measure the presence of DOAC in the acute setting. Now let's look at that. This is the overall efficacy. And what you have to appreciate here is these studies were designed as non-inferiority. And why is that? Low molecular weight heparin, vitamin K, is probably one of the most efficacious medical treatments we have in medicine. It's about a 90%, and sometimes even 92% relative reduction of low molecular weight heparin followed by vitamin K antagonists. So what we actually have today, the standard treatment of low molecular weight heparin and vitamin K antagonist is extremely effective. Very different from, for example, stroke prevention. Warfarin, or vitamin K antagonist, in the setting of atrial fibrillation, is only about 63% relative reduction. So there, in the setting of AF, you actually may be happy to see an improved efficacy. In the setting of VT, that's not necessary. So the fact that it is non-inferior, this is the cumulative estimate, as you can see, really very tight confidence interval. So you can be absolutely sure that they are as good as what you have right now. Now, these two here are open label, and the rest are double-blind studies. And there really is no evidence that there is a difference there. And then finally is this testing. Now, this is under development. It's this company and a couple of other ones that actually now try or have initial results that suggest that with a drop of blood in the emergency room, these machines and other machines, so it's not an advertisement for this particular machine, but this is one I could find on the internet, is where they are able to detect, is there a thrombin inhibitor on board, is there a 10A inhibitor, or is neither on board, and also some quantitative elements in that. Let me therefore conclude, my dear friends, are you finally convinced? And yes, I am. This concludes my the part on the DOAC, and I'll spend the last 20 minutes on what to come. And I don't have much data for you to show, except that I do really believe, and I'll show you some of the data, it is absolutely time that we are going to study statins. And I know there is an initiative in Canada, and there is an initiative in Norway and some other Scandinavian countries together. But I'll show you the data. Statins is a perfect drug in the setting of preventing recurrences. I'll already noted the 11 and 12, and I'll share you two pieces of data. I will not show you the TAFI inhibitors and the PI1 inhibitors. Both of these will be studied clinically, and these trials will begin in the next couple of weeks. And this is TAFI inhibitors, or PI1 inhibitors, on top of anticoagulant therapy. So what they basically try to do is elevate, if you want, the endogenous fibrinolytic activity. This will be done in patients with large PEs. And hopefully that study the phase 1-2 study, or phase 2 study, will start very soon. Let me just share with you what I now really believe, and the president of this conference, Fritz Rosendahl, has published the last paper on this topic of statins in the Journal of Thrombosis Hemostasis a couple of weeks ago, and really shows exactly the same as what I show you here. This is the study I was involved in based on the data in Denmark, and Suzanne Kannegieter looked at the same set, slightly different, but came to the same conclusion. As you know, Denmark is a unique place where there is a very good documentation of drug use and outcomes. And so a perfect place to ask the question, those patients with a venous thromboembolism that had a statin compared to those that had not a statin. Now, of course, there was a reason to give a statin. Most likely cardiovascular disease. So you need to correct for that. And if you do that, as you can see here, this is the outcome. And again, I don't want to bother you with the nitty details, but what I'd like you to see here is that there is about at least a 25% reduction in the occurrence of a second or third episode of venous thromboembolism. This is a drug that has been used by billions of people. We do know the safety profile. It's very cheap. 1 year of statins is about €3 nowadays. So if it is true that with a simple addition of a statin, because this is statin on top of anticoagulants, we are able to reduce these frequencies of recurrences, that would be really fantastic. And again, it's time that we do the studies. Let me then close with what you heard in the very elegant presentation this morning from Thomas René, and that is, I'm not good at this, is really, we have been focusing for a long time on this part, of course, the extrinsic pathway, and actually all the anticoagulants we have these days are affecting somewhere the 10A, the thrombin inhibitors, etc. But it is really this one where factor 12 gets activated to factor 12A and factor 11 to 11A where the action is. Because as Thomas showed this morning very elegantly, there is this promise that if you do affect either of these proteins or these enzymes, that you actually may be able to prevent thrombosis and get no bleeding as a punishment. Now, in a very recent and very nice, I should say, overview from Jeff White's in thrombosis research in 2016, what he really does here very nicely, you see factor 12, you can do that with the antisense. Now, for those of you who are not familiar, antisense really in the liver inhibits the synthesis of factor 12, reduce hepatic synthesis of factor 12, and this has also been available for factor 11. Then you have antibodies, you can read it by yourself, for factor that bind factor 12 and blocks its activation. In factor 11, similarly, although you have more sites where you can block, of course, the active site or the protein altogether, there are small molecules. There are at least 4 or 5 small molecules in the setting of factor 11. It's not reported for factor 12, but they must be there. Allosteric inhibitors, again, bind to the charged residues in factor 11 and modulate factor 11 activity. And then finally, the Optimer is one that binds factor 12, and it's not reported. This should be here. At least 11 companies are working on either 11, 12, and some on both of those ones. So we will see a tsunami, if you allow me, very, very soon. Now, I had the privilege to chair a study with a company that has changed its name. The company was called ICES in California. And I remember the first time that I went over to California to talk to them for talking about the clinical program. They said, don't worry, you get out of the plane and you come into the entrance hall, and I will be there with a sign saying ICES, and there will be nobody around me. And he was correct. It's now called Ionis, by the way. But these guys, very good scientists, they developed this antisense for factor 11. And they asked us the question, what should we do? And they want to do another baboon study, and another animal study, another mice study. And said, let's bite the bullet. If it works, you have to go to the model of knee surgery. Now, I don't have time to really go into all the details, but I'll go quickly, and I'm sure that some of you have seen the data. But what we've done here in this study, we have taken patients that underwent elective knee arthroplasty. Now, for those of you not familiar with that, that's a big surgery. You know, they basically cut out parts of your knee and they put in metal in place of that, instead of that. And what we did here is we looked at 2 doses of this antisense. It has to be given 3, 4, 5 weeks before the surgery, so it's not really ideal, but this is a proof of concept. And that was compared to enoxaparin. Now let me share with you what happened here, because it's unique. Any other coagulation factor, except factor 12, of course, these were the concentrations in the highest dose, which was the most effective dose, of factor 11 at the time of surgery. So this is about 20, but the standard deviation, there were about a third of these patients had less than 1% factor 11 and underwent surgery. Now, if you want to have a good test, whether that induces bleeding, this is the one. But what is the most impressive finding, dear colleagues, is this. If you give enoxaparin, as you can see, the frequency of thrombosis is 30%. And if you are interested what it is, but this is the figure, about 30% of these patients develop a thrombosis detected either by venography or clinical symptoms. What about the 200 milligram. Now the 200 milligram, as you can see, 26.9, very similar. But the big surprise with factor 11 reductions to about 10–15% of normal is what you see in the 300 milligram. Only 3 clots, 4%. So thrombosis in this very thrombogenic model disappeared almost completely. And if you look at these 3, those are clots about that size. While if you look at the clots that are here, you can see it here, proximal ones, they are bigger clots. I don't have the data here to show you, but the bleeding in the 300 milligram group was less than the bleeding in enoxaparin. And for the first time in my life, I've never believed that we could develop an antithrombotic agent that does not cause bleeding. But these preliminary data really suggest that targeting factor 11 may actually be a target that will deliver what we want, the prevention or the treatment, if you want, of venous thrombosis and arterial thrombosis, and not having a bleeding risk. We are very fortunate that in the same setting of knee surgery, we hope to start very soon another antibody in this case in order to see whether we can reproduce those findings. So, Mrs. Chairperson, let me just conclude. And I think I've tried to provide you evidence that vitamin K antagonists are on their way out. If I would develop a venous thrombosis tomorrow, God forbid, I would know what I need to do. DOACs are the drug of choice at the present time, and the future is extremely bright. Thanks for your attention.
Thank you very much, Harry, for this really complete and comprehensive overview of past and future. We have 10 to 15 minutes of discussion. I see Professor Manucci. Anybody of you have comment or question, please come to the mic and present yourself.
Manucci, Milano. Harry, I haven't got mustache and black hair, so I'm not the bad guy. And altogether, I agree with you nearly 100%, even though I'm more cynical than you and less enthusiastic, because when drugs are in the first few years, usually problems do not come about, they come about later. But I hope to be wrong. The only point that I need some clarification is the story of the elderly. You did show quite clearly that people that are 75 or older respond equally well or perhaps better to the dogs. But the problem is which 75 years old or older, because there are people like me that are very fit, they look younger, even though they have white hair, but there are many that have take multiple drugs, have many diseases together, and I'm quite sure that in these studies, even though the number, as you said, of more than 35-year-old irrelevant, they didn't enroll the people with multiple morbidity, frail, and take multiple drugs that can react with the anticoagulant. Can you clarify and perhaps deny what I'm saying?
No, thanks very much, Professor Manucci. That's a good question. There are two elements. So the real-world data for venous thrombosis are, as we speak, is generated. And I do encourage them, if you do it in the right way, with the correct statistical techniques, we can learn something of that. If we go to the AF, I showed you the one from the FDA, but about 4 or 5. And they all show the same thing. The absolute rates may be a little different, which is a part of your second question. But of course, what it's all about is the relative difference. Now, to answer your second question more precisely, if you look inside the study, if you define it either by age or age plus renal insufficiency or age plus renal insufficiency and low body weight and polypharmacia, the message remains the same. So what it tells me is that these, let me take the elderly, is, because that's where we have a lot of data, those do a bad job on warfarin already. And the relative benefit of the DOAC is maintained. I hope that answers your question.
Willem?
Thank you. Yeah, Willem Leijfink from the Netherlands. I have a question actually about the good versus the bad guy. It really triggers my mind, I think, here. I always learned that good versus bad guys, if people make up those stories, that it says more about the people who make up the stories than about the definition of who is good and who is bad. But considering that I am a bad guy, probably because I was not convinced by your talk, so I had to ask this question about the DOACs. There are a couple of things for which I'm not convinced that DOACs actually are as good or maybe even better than vitamin K antagonists in the trials as compared to the situation that is outside of the trials. And there are four things, I think. One is the comparison. So the comparison is compared with vitamin K antagonists, of which the TTR was on average, I think, about 60%. And that's pretty low if you compare it to other Western countries. The other thing is the persistence and the adherence to DOACs are probably much better in the experimental studies than in the real-life situation. And the third thing that I'm quite concerned about with the DOACs actually is that if you measure the levels in the blood, then we know that the higher the blood concentration of the DOAC level is, the higher the risk of bleeding. But still, we do not monitor these patients at all because it's a fixed dose. This is what is being told to us. Well, we know that if you would measure it, that you will see that the higher the level of a DOAC is, the higher the risk of bleeding. So that doesn't say that they are actually better or worse than VK in real-life DOACs, but what it tells me is that I'm still a bad guy, I think, because I'm still not convinced that they are better.
No, thanks very much. I'm very pleased that I triggered you, because that's exactly the reason why I put the bad and the good guy there, so it worked, at least with you. You're still not convinced. My simple answer is always, in God we trust, the others have to provide data. Now, I've tried to show you data over and over and over again. So the gut feeling, I'm not convinced, is hopefully, if I give my next presentation of even more data, I can convince you. Whether the real world, because, you know, I hate actually the real world, because, and that's a part also to the answer to Professor Manucci, is the Western physicians participating in these studies is a very small proportion. So we are very fortunate in these trials that we actually have people from all over the world. And those are not thrombosis specialists. Those are just simple treating physicians that put in all their patients. And that, in my mind, is the reason why the representativeness of what goes into the studies comes so close to what you see in the real world. It really is the sophisticated, knowledgeable doctor that thinks that he is able to, let's say, influence recruitment. But God thanks, most of the patients actually come from other parts in the world where that doesn't work. Now, your last point is the measurement. I thought about putting that in because that's all, in my view, almost the last line of defense. Say, vitamin K, we can measure that, and we do such a good job. No, I've shown you the data in the elderly. I've shown you the data in the renally impaired. And that was very careful, high-quality vitamin K antagonist. Actually, a quality of vitamin K treatment which is above what happens in the real world. So I'm very, let's say, optimistic of what we're going to see in those real-world studies. Now, whether measurement of the anticoagulant effect really improves the outcome of these patients is still in great doubt. I don't know what the answer is, but the problem with the half-lives, the problems when you have to measure after 2 hours or after 4 hours or 10 hours, and what the subsequent action should be, all that is unclear. And so those people, and I'm not an expert, those people who really are experts in this, really believe that at the present time, when we don't know what the therapeutic range is, when we don't know how to change the dose, we don't even know what to measure, when to measure, and what to change. If we get answers to those questions, then it may become possible to say, can we prevent some of those people that apparently are very high, and does that change their outcome? The gut feeling would say yes, but I can tell you low molecular weight heparin, we're given in fixed dose, and the same is true there.
Thank you. Professor Rosen, the last question.
Yeah, I have a slightly different question, Harry, a methodological question. As an editor, we now get all these real-world manuscripts, and you're a trialist. We do randomized trials because we believe the real world is confounded. So do you think these have any value, these real-world data?
No, Fritz, I'm very happy you're asking that. I actually hate real world, because it suggests that what happened in the trials is not the real world. And the patients that are there, and I can give you many other subgroup analysis of the type of patient, but that are the patients that you and I see. That's why I believe these real-world studies is very often seen as an excuse to keep busy, but whether they're going to be really showing anything else from what we've seen here. Now, the FDA 136,000 study in AF patient was done because the FDA was convinced that in the real world it would be different. And what I've tried to show you here, it actually comes out quite equal.
Thank you very much.
Is there one more, or is it not allowed?
If
No?
it's very short, because we are over the time, another session they are starting. Is it short?
Or I'll come to you to answer the question.
Yeah, I think it's better. And on behalf of ECTH,